Our panel discussion is including not only our moderator, but we have 9 panelists on this discussion of different training levels, of different specialties and disciplines of medicine. And so the panel discussion is entitled Promoting Diversity, Equity, and Inclusion Within an Academic Healthcare System. Our moderator this afternoon is Dr. Natasha Mickel. Dr. Mickel earned her doctoral degree at the University of Oklahoma, and at the University of Oklahoma Health Sciences Center, she is an assistant professor in the Department of Family and Preventive Medicine. She is an assistant director for faculty development, director for the Oklahoma Center for Mentoring Excellence, and director for multicultural engagement for the College of Medicine. Within her roles, Dr. Mickel supports a variety of professional development opportunities for faculty at OU Health Sciences Center. Her vast experiences have allowed her to acquire a unique set of skills that has allowed her to collaborate successfully with a diverse body of learning communities. So Dr. Mickel, I thank you so much for being this panel moderator this afternoon. And I'm going to turn it over to you to introduce our guest panelists.
Sure. Well, thank you so much. I'm happy to be here. I see my background has made sure I had a bouffant a little bit, so I'll take it today. I like to keep things positive and light, so I hope that this panel is informing and also that you join us in asking questions and being informed by the things that our panelists are sharing. So I am Dr. Natasha Mickel. I have nothing to disclose. You can find all of the panelists' disclosure information in the online syllabus. Please use your chat box to post questions, just like you have done throughout the day, and comments for each of the panelists you can put in the chat. I'm going to start, and I did not say every single thing with the titles because some of you are so accomplished. I wanted to get through everybody so we can get to our questions. So pardon me if I don't say all your titles, and pardon me if I also don't say your name correctly. You can also unmute yourself and correct me. So Mr. Jamalje Bassue, he's a third-year medical student at OU College of Medicine. And yes, just do a little wave then when it's your turn so you can know, we know who you are. Dr. DiAnne Davis, who may join us a little later, is a dermatologist at North Dallas Dermatology Associates. So she's not on right now, but she may come on later. Dr. Sacharitha Bowers, dermatologist and associate professor of clinical internal medicine at Southern Illinois University. Miss Carrie McClain, inaugural Chief Equity, Diversity, and Inclusion Officer for the Tulsa City County Library. Dr. Trinitia, Associate Professor and Director of Head and Neck Surgical at Duke University. Mr. Joseph Monroe, which may join us a little bit later too, founder, past president, and fellow for the Society of Dermatology Physician Assistants. And then we have Mr. David Conkerite, Associate Vice President for Diversity, Equity, and Inclusion at OU Health. Dr. Susan Taylor, dermatologist and endowed professor at the University of Pennsylvania, Perelman School of Medicine. And then Ms. Lauren Dankwa, which I believe may join us as well a little bit later, is a clinical nurse specialist and hospitalist for OU Health. So that's who we're going to have today. We're really excited to have these questions, some of which pertain to dermatology and the specialty itself, and then other generalized questions about DEI. And of course, if you have an opinion as panelists, you can chime in at any point. So the purpose of this, I'm just going to go through and make sure that I read the purpose and learning objectives and professional practice gap. The purpose for this panel is to increase the knowledge of its attendees regarding skin of color, conditions, and identify diversity gaps within the field of medicine. Some of the learning objectives that we hope to accomplish today is recognizing the challenges and barriers to recruit individuals from underrepresented backgrounds into medicine, examining organizational culture and climate and its impact on DEI, as well as illustrating strategies to address the DEI needs of academic healthcare systems. So our professional practice gap, we liked to come up with something that we think is going to be really important for you to understand as you're trying to further your professional development. So we've said that many providers, faculty, and medical students do not understand the value and necessity for diversity, equity, and inclusion awareness and implementation within an academic medicine system. Upon completion of this panel discussion, participants will gain an appreciation for the role of DEI and cultural humility in the healthcare field. So with that, we're going to go ahead and get started. So our first question is a little bit twofold, I should say, and it poses, what does diversity, equity, and inclusion mean to you, and what does it look like in the academic healthcare system? What we want to talk about is why DEI is important in an organizational system, because we know that there are some faculty, trainees, and students that feel they don't understand why it's emphasized and why it feels like it's overplayed per se. And so what does it look like also in medical education?
I'll jump in.
Okay.
So for me, diversity, of course, means who's in the room. And having people of different backgrounds in the room makes the organization stronger, as Dr. Gannon had a slide. We are better advocates for our patients. Our patients get better care. We take care of patients who are underinsured or uninsured. We have a certain amount of more cultural competency in many respects. We perform research that benefits people of color. Equity is who's trying to get into the room and who can't. So we need to provide a pathway. We've talked about it today for our high school students to college, our college students to medical school, our medical students to the residencies that they want. We have to make sure that people are in the academic room, so to speak, at major medical centers, so that they can not only care for patients, serve as role models, serve as mentors and sponsors, and perform research. And inclusion is everyone's idea, are everyone's ideas heard? Is everyone engaged in the conversation? And that just goes back to kind of where I started, enriching the whole organization.
Thank you so much. Would anybody else like to include a comment?
Just to include a comment onto that, I think that from my experience, although I'm no longer in the healthcare setting and have been gone for about the past 3 months, but my previous experience within higher education and more specifically our OU Health Sciences Center campus, I think that so many times that people get caught up in the word diversity before being able to then really look at and understand what equity and inclusion means and why those things are so important. I've come to realize and kind of see that there's so much discussion around what diversity looks like, what it means, but also being stuck between that binary of race and gender that we can't see outside of that. And that begins to hinder us really being able to understand the importance of the equity and the inclusion, which are the bigger pieces that we really have to look at.
Thank you so much. Anyone else like to give a comment?
I'll echo what's been said, and I think the point about equity is so important because as physicians, I don't think there's a physician that I know or that is here today that would want to have any of their patients not get the highest quality care. And to Dr. McClain's point, it often becomes about, oh, are you picking people because of their skin color? And people tend to focus on that aspect of it without understanding, why we do it. And at the bottom of all of that, the foundation of that is we want everybody to have, the benefit of high quality medical care. Everybody to have access to that. And I think when we phrase it that way, it's really hard to argue against that. And then you kind of work backwards. What does it take to achieve that? So that's kind of how I like to think of the framework is, what's the ultimate goal? And then what do we need to do to get to that goal?
Yeah, definitely. And then, I do hear that's often here in the medical setting where people feel overwhelmed. And one of the sub questions within that was, what do you say to some of the leaders, the students and the administrators who don't understand why it's important and feel like it's overplayed?
To answer that question, Dr. Mickel, and the second part of the first question you asked, why is diversity, equity, and inclusion important at academic medical centers? And I think the importance of it is because we're a teaching facility. So we're training the next generations of clinicians to go out and serve the community and serve the world. And if we don't have diverse perspectives and teach them how to meet the needs of the communities that we serve, then we're not fulfilling our mission with really providing that excellence in teaching. And so right now in our country, we've got a certain climate happening right now. And some people, as you said, may think that the conversation is overplayed, but that's really just because it's been brought to light in the national attention. But we've had the data for years that has showed why this work is important and why we need to make sure that everyone has a seat at the table so that we can continue to meet the needs of our diverse world and the community that we serve.
Thank you so much. All very valid points. Thank you. Anyone else would like to a last minute comment before we move on to the next question? Okay. Well, the next question, very similar to what we just talked about, but can you speak to specifically in your environment or maybe what you've seen in the national news or you have colleagues, some of the barriers and challenges to achieving DEI in the academic healthcare system?
I'll go ahead and be the first to comment on that. From my experience, I'd have to say that the lack of support, the human capital that's needed to do the work. Oftentimes, when we bring in this focus around DEI, our intentions are good and we really want to do better, is what I have experienced. But oftentimes, I think there's a disconnect from how many people it's going to take to really move that needle and get the work done. And so I've seen in various spaces where you have one or two people leading that work. And when that's one or two people leading the work for an entire college or a campus or university, where you are focusing on faculty, staff, students, trainees, that is a lot of work for those few people. And so I think understanding the amount of human capital you have to do the work and to improve, to make improvements has been a barrier, in my opinion.
Thank you so much. Yes.
Yeah, I second that. Like you said, it's always often a few people on campus doing a tremendous amount of work in order to make this happen. Oftentimes without support of, administrative support, financial support, things to kind of make this process a success. In addition, they're doing this along with doing their other work. And it sort of oftentimes becomes the background work, the things that you spend a little bit of time on in the end of your day when you have time to do it. And the initiatives just need to be made in order to make the forefront. It needs to be the center, and then everything else expands from that. And universities haven't figured that out yet.
Okay, thank you so much. Did you have something to add, Dr. Bowers?
Yeah, I also, one of the other things I see, and it's a challenge, and I don't have an easy answer to this, but I often see diversity, equity, and inclusion work siloed, within like, okay, this is the DEI curriculum, right? Or this is what we're doing. And, we don't do that with high quality care or quality improvement or patient safety, right? So, it should be just really woven throughout. And I think it's a challenge because it will require changing a lot of ways that we've done things, changing curriculum, changing the way our clinics look, changing how appointments are made. So it's a complete system shift. And that's, of course, overwhelming. And that ties into my second point, that it's the other challenge that I've noticed is that it's hard to change norms and the way people do things. And especially if you're in an environment where, there may not be a lot of other people working on it, or you may be in the minority, even getting the buy-in initially can be challenging, kind of getting the support and the understanding that this is important and needs to be looked at just as much as the EHR or your clinic workflow, right? And then on top of that, beyond getting the buy-in, then how do you get the system buy-in to get the funding that you need and the time that you need? Because it truly permeates everything. It's not just about a talk or a lecture or just learning about how skin of color looks in pathology. It's about all of it and how it affects everything. So I think those are other challenges I've noticed as well, in addition to what Dr. Cannon and Dr. McClain have mentioned.
Thank you so much. Yes, definitely. Did anyone else have anything they wanted to add to that?
Just to add to Dr. Bowers, I think the important piece that's missing with making this work integrated into all that we do in our healthcare systems is the accountability. And so we know that there's no mission without a margin. And we've got to have the metrics in place to hold our leadership accountable so that we can meet the objectives that we're trying to achieve, and so that it doesn't just sit with one person in the office or two people across the campus. And so that's the missing link, I think, to moving forward in this work, is having standard measures of excellence that we can hold our systems accountable to.
Yeah, I agree. Thank you so much. And also for the leadership and administrators, for them to be knowledgeable about what that means. Because too often times we do see that we'd like to see a change in a year or two. And we know it could take a decade for you to see some incremental changes when it comes to increasing faculty and students. So I think educating also our leaders and people, our stakeholders, about what it's really going to take and how long it could potentially take to see those changes within our system. Jamalje, I'm curious, because you're seeing it from another perspective as a student. So do you see some things that you could share with us from your perspective about some of the barriers for DEI in our healthcare system, particularly in the academic area?
Yeah, and thank you all so much for having me, by the way. My name is Jamalje. I feel really honored to be here right now with some of the biggest names in dermatology. This is really cool. But yes, I think I offer a unique perspective on this panel, just because I've spent so much time over the last 3 years building and forming relationships with a very select amount of people that I can truly open up to and relate to. There's a lot of them on this call right now. I don't know if Dr. Cannon remembers me. You might have left before we got really close, but in my first year, I came up to you and I talked to you. I don't know a thing about ENT, but I just wanted to have that presence and just feel comfortable in these spaces. And I feel like a lot of students like me, you can go a long time in the medical education realm without seeing people and representation like yourself. And so just seeing these faces, that's gonna boost or will to keep pushing. It's gonna make us feel more comfortable. It's gonna give us that metaphoric, seat at the table. And it feels really good. So I echo all the comments on interweaving this into everything. It should not just be, as Dr. Bauer said, it should not just be siloed off into one corner, the DEI corner. We have to make sure that changes made are widespread and all-encompassing. It has to be permeated through a lot of what we do in medicine.
Thank you so much for sharing. And welcome Lauren, who's the clinical nurse specialist and hospitalist for OU Health. She'll be joining us now, and we'll go into our third question. So the question is, what is the relationship between DEI and health disparities? And more specifically, some of the examples like ethnic minorities with higher infant mortality rates, higher breast cancer mortality rates in Black women, and increased premature heart disease and stroke mortality in Blacks. So that's just a limited amount, but just as an example. So can anyone speak to the relationship between DEI and health disparities?
Can I speak?
Sure, of course.
Okay, so I work in the ER. I'm on the hospitalist team, and so I divvy out patients to all of my hospitalists. I work with maybe 10 or 11 of them per day, and then I also see patients. I think those things are directly connected because all physicians have different personality types and whatnot, and some are more dismissive than others when it comes to patients and how they express whatever pain they're going through or whatever ailments or symptoms, and your body. But I do notice, and I do have to redirect sometimes when I am asked to see a patient, do a note, and sometimes, especially with people of color or people who speak a different language, the patient's symptoms are sometimes dismissed or not taken as seriously as people who are not of color, depending on their status, depending on, we're not supposed to do this, and I vehemently disagree with this, but we have some patients that are treated like they have a better status or a bigger status because of what they do, who they are, people that are in positions of power, all of that. And I will tell you that sometimes I do have to redirect physicians, be like, hey, maybe we should take a look at this. Maybe we should go ahead and order this echo. Maybe we should go ahead and order this MRI on top of the CT and not just send them home because they could possibly have a stroke or had signs of a stroke that weren't caught with a head CT. So the disparities are real in that sense, especially with people of color, especially with women. Not listening to Black women that have issues that aren't being heard. Most of the time when I have people that talk about being, sent back home multiple times, I have frequent flyers. It's not because they want to be a frequent flyer, it's because they want to be listened to. So that's something that, and once you get that pegged in your chart, and you have a physician that'll get that information, and then they'll say, okay, well, they're a frequent flyer. Well, if you listen to the patient and take the time to do the history part of the history and physical, you might be able to get to the root of the issue, and they may not be a frequent flyer if we take care of the real problem.
Wonderful. Thank you so much for sharing. Anyone else want to comment on that? Things that maybe you've seen as a physician or as a student or administrator, that connection, relationship between DEI and health disparities?
I think Lauren made a great point about the bias that we see in healthcare and not believing. Sometimes our healthcare systems don't believe our patients when they're talking about their symptoms. And then what I've seen is that trickle down through families for generations when it comes to access to healthcare or really not wanting to be a part of anything related to healthcare. And I'll use my grandmother as an example. She knows every natural remedy you could probably think of to avoid going to see a physician. And then now when I spend time in the community, particularly on the Northeast side here in Oklahoma City, I often will ask, do they have a primary care physician to someone I'll meet? And they'll say no. And so there's a lot of people within our underserved communities that have limited access to healthcare, either through poor experiences where they just avoid it, or also maybe lack of insurance or lack of just understanding how to actually sign up and get a primary care physician. How often should I be going in for checkups? And then when they come into our healthcare systems, not having the time afforded to them to really share about their history and to really develop a rapport with the provider so that they feel comfortable and really digging deep into their healthcare situation.
Thank you so much for sharing. That actually brings up something for me too when it comes to that relationship between DEI and health disparities and our history of distrust within the medical community, and how we as different underrepresented communities haven't really truly healed from some of those things generations ago, and how we have to understand and really take that forward of how people may be feeling when they come to the doctor.
One of the last things that I did before I left the university was that we did a big community event where we went out to churches and talked with some of the Black church pastors in the community. They were all invited to come, and we had a pretty good turnout. And they were representing their communities, obviously. And I did a whole talk on not just head and neck cancer, but prostate and breast, and sort of what the death rates were compared to non-Black people. And we're doing all this talking, and they had a lot of questions which were great. And one of the questions I asked was, who has a primary care doctor? And a lot of them did. I was very happy to see that. And then I wanted to know, so what has the primary care doctor offered you or told you that you needed to have done by this point? None of them had colonoscopies. None of them had prostate exams. None of this was recommended to them, at least from their perspective. They hadn't even known that this was something that they needed to do, you know. And I often find that, when you come in with some knowledge, some understanding, have done a little bit of research, then some providers will meet you where you are and then, promote that. If you don't, then you come in and all they're doing is checking your blood pressure, because that's something that we know that happens amongst our community, or checking your blood sugars because that's something that happens amongst our community. But they don't see anything else. And so I think that that's, a big factor, just not being seen, not getting told the same information across the board. Other stereotypes we talked about, I've had so many patients come to me, and then in the end, they will tell me, big old neck mass, 7-8 centimeters sticking out of the side of their neck, that have been there for, 6 and 7 months, and they've seen 2 and 3 different providers. And oftentimes, I gotta admit, sometimes I'm like, that's not possible. Like, it is just absolutely not possible for you to have seen, I'm thinking this in my head, for you to have seen somebody and told and shown them this, and they've ignored that something. So then of course I get to going back and, typing like Charlie Brown on the keyboard, trying to figure out all the notes and everything. And sure enough, it'll be written in their story. They won't even have mentioned it in their note that they have a neck mass that's 8 centimeters on their neck. And so it's amazing for us not to ever be seen, and not heard, not listened to. And that's something that just truly has to change. The knowledge has to get out there some way. And it's going to take some of these efforts to bring it to the community, because clearly that individual approach of just going to see your doctor is not helping.
Yeah, definitely.
I want to just add on to
Sure.
what Dr. Cannon said. I'm so glad, thank you for bringing up that point, because so many of us who are not Black don't understand that, don't understand that historically derived mistrust. And when you don't understand it, and as I've come in my own DEI journey to learn to understand it, the only way you understand it is, like, you got to get out of your clinic rooms and you have to talk to people, because they're not going to come to you, and we're not going to learn it. And to understand that mistrust is so key to, our DEI efforts being successful, because if we rely on patients coming to us, we're going to miss it. And so I think that gets to, what we saw with the COVID-19 vaccination, and so many of the efforts that were done to get vaccination rates higher for Black and Brown communities were all done in the community. These are, like, I call it grassroots. They're grassroots efforts to go out into the community and have community-led vaccination efforts. And that's a complete paradigm shift for how medicine works, which is, okay, we have our one brick and mortar institution building, everyone come see us, versus, changing our paradigm to people aren't coming to see us, so we need to go out to them. And of course, they're not going to come see us because we've done nothing but earn their mistrust. So, and I know I'm going to call out Dr. Elena James, who's at Pitt, who has done a lot of work on community engagement and how that, benefits patients in marginalized communities. So I think that's the other connection with DEI and disparities, is just changing our idea of how we deliver healthcare. And that has to be a part of it. Otherwise, we're going to miss it.
Right. Thank you so much. Anyone else want to comment? Okay.
I just want to say one thing
Oh,
that
please.
is semi-related. I wanted to say that I really appreciate that there's an actual website that is dedicated to this, that the public can see. It's not just an internal deal that we have for employees and staff only. It's for patients, if patients wanted to look it up and see that we have this program. And it's important because the trust is on both ends. I think that they can see that we're working toward it, that we have dedicated resources and people to this, that maybe we can gain some of that trust back.
Yes, thank you so much. Some of the groups that I know you are mentioning, and that would have been possibly mentioned through David in the hospital, of trying to bring the community together so we can listen to their concerns, and to continue with that throughout our journey here. Because what often happens is that a group will come in 2 years ago and do a little bit and leave, and then we come in another 3 years later and do a little bit and leave, and there's not the sustainability, and there's that mistrust that comes into play. So I do agree that making sure that there's information that's always there, and there's always a person in place. When someone leaves, someone takes their place and can answer those questions. So thank you. I will jump to something more DEI related. There is a question here that says, why do you think white or light skin tones are overrepresented in medical school and training textbooks? More specifically, do you think it's affected medical education, and how is this issue being addressed?
So the answer is definitely it has affected medical education. Textbooks and all a host of resources focus on white skin because there's been such a paucity of people of color within dermatology, within medicine, right? There was another question about health disparities and the differences in 5-year survival of melanoma, which is about 77% for Blacks and 90-some% for whites. It's felt that that's not due to any inherent difference in the melanoma, but it's due to delays in diagnosis and hence treatment. And diagnoses are delayed because physicians are not adequately trained to understand what melanoma looks like in people of color, that it's acral, it's palms, soles, nail beds, mucous membranes, right? So if you don't know it, you're not going to make that diagnosis early, and that's going to impact your patient's survival. So if it's like a chicken and an egg, if you can't make the diagnosis because there are no pictures, in the textbooks, for example, then how are you going to improve? Well, I'll tell you how to improve. You get people who look like me and you who see these patients, and we can further the education, right? There are efforts being made right now from a variety of professional societies, the Skin of Color Society, the American Academy of Dermatology, to begin to educate our colleagues and our trainees on skin of color, to get image banks of patients with skin of color, to have integrated in textbooks images of patients of color, because our diseases look different.
Yes, and I agree. It was not too long ago, maybe about a month ago, I was scrolling through LinkedIn like we often do, and I came across an image, a medical image of a Black mother and the Black baby within her stomach. And I had like paused, and I couldn't believe, here I am 40 years old, and it was the first time that I had seen a medical image of a Black woman ever, of a baby, or any kind of medical image. Every time I had seen one, it was a Caucasian. And I thought, oh, we've gone so far. And when I realized it was the first time I seen it, I couldn't believe it. I really was just like astonished.
Yeah, me too.
Yeah. Dr. Bauer? No, please, Carrie.
I was going to add, I think that this question takes me back to the first, one of the first few questions that you asked in terms of the importance of DEI. If we think about who are the authors, or who are the people making and collaborating on these textbooks and putting these textbooks out, what do they look like? What experiences do they have? And that then going back to that question of why DEI is so important in this space, having that representation at the table when making textbooks, when we're considering people from all backgrounds, and to think about, you're going to come into contact with people from all backgrounds. But if you have kind of a monolithic of those at the table, then you don't have that opportunity to do that.
Thank you so much. Well said.
I was wondering if I could just
Of course.
say something real quick.
Yes.
Thank you so much. I just wanted to tackle this from two different perspectives. From the institutional perspective, and I sort of spoiled it. I accidentally sent something in the chat talking about the institution, but I wanted to talk about it from the institutional perspective, because OU has been actually doing a pretty good job with the input of students of color, in revamping and reassessing their didactic lectures, some of the material that we learned in the first 2 years and even beyond then. And the only reason that stuff comes around, and the only reason we have the opportunity to do stuff like that, is because we have more representation now in our medical classes. It's not where it needs to be, of course, but these things don't happen over, you know, the course of a couple years. So that's the institutional perspective, but also I remember when I started my clinical years, so third year, I went into the dermatology selective, which is a 2-week program that we have here. And I remember shadowing Dr. Allen for some time, and she showed me what is known as she showed me what is known as DPN. And that was the first time that I saw something like that described the way it was described, even though it's so common in people that look like us. And I just figured that I should have known about this way before. And it's sort of embarrassing that I didn't know about it, but it's not a fault of mine. It's just because we weren't exposed to those things in our first 3 years. And I later learned that DPN is just a subtype, or even another, it's related to a really common thing that we see in white skin that I learned about, which is the seborrheic keratoses, or seborrheic keratoses. And it just manifests different in Black skin. And if somebody had told me that in the first 2 years, I would not have shown up embarrassed in front of Dr. Allen, but yeah.
Thank you so much for sharing. Did anyone else have a comment about this? And anyone else that can, it is we pose it to the dermatologist in the panel, but of course, like Carrie said, the representation across all things, maybe Dr. Cannon, what you've seen within your discipline, and David, what you've seen on the hospital side about representation and how that really matters and it can affect people of color. So any other last comments? Okay, well, we'll move on to another question. What are the factors that affect dermatologic health disparities? And some of the examples, people of color have higher mortality rates from skin cancers. So Black patients with melanoma, which I think Dr. Taylor had spoken about briefly, have 5-year survival rate of 67% versus 92% for whites. I believe you said 77% for African Americans. Hispanic populations that may be understudied and undertreated in melanoma, as well as atopic dermatitis that's more prevalent in ethnic minorities. So can you speak to some of the factors that affect dermatologic health disparities?
Do you want me to speak again, or should
Sure, you can speak. No, it's fine.
Well, I think it's more of what I said. Lack of training leads to incorrect diagnoses or no diagnoses, which means patients suffer, which means patients with diseases that are fatal. There's increased mortality in addition to morbidity. And I think it all there's lack of research. So let's say you make the correct diagnosis, but there's not research about either the disorder itself or, the different manifestations of it in people of color. So it's just circular, the problem.
Definitely. Thank you so much for sharing.
And I'll also add that I think when it comes to treatment, there can be, cultural factors related to cultural competency in how, in patient care practices, in understanding things can be different in people with different backgrounds. For example, people with Black hair versus people with, non-Black hair, and what we tell them to do when we're treating their seborrheic dermatitis is very different. And, if we don't have the cultural competency to understand Black hair and the hair care practices in the Black and African American community, we're going to fail at treating those patients. And it's not that they are non-compliant, it's that we have missed our opportunity to be, you know, culturally competent. And again, this all is connected, right? It's not like its own issue. It's what we are trained in our textbooks. It's what faculty we're exposed to, who educate us. It's, you know, all the different learning resources that we have access to. And it's also the patients that we have in our clinic. So if our patients have this earned distrust of coming in to see us, rightfully so, we're gonna, it's again, like Dr. Taylor said, it's like a chicken and egg thing. We're gonna have less exposure to those patients, and then we're gonna consequently be less likely to diagnose them because we just don't see a lot of it. And, you know, I can speak to this at where I'm at in Central Illinois. Our population of Black patients in Springfield is actually a little bit higher than the national average, but it's certainly not what we see in our clinics. And so our patients are there, but like they're not coming into our clinic, right? So our patient population is heavily white, but we're still not seeing the degree of patients in our clinic that are actually present in our community.
Thank you so much. Dr. Taylor?
Yeah, one more point I'd like to make. Many of our psoriasis patients are treated with biologics. They are the new emerging treatments that work very well. There's a study that demonstrates that there are differences between Black Medicare beneficiaries and white Medicare beneficiaries in the being prescribed biologics for psoriasis. And 70% of Black Medicare beneficiaries have never been prescribed biologics for their psoriasis. Same insurance plan, same reimbursement, same disease, but we're not prescribed, what's considered now the standard of care. And that's really across the board. Acne patients aren't given spironolactone or oral antibiotics, right? So even if the correct diagnosis is made, there are huge disparities in regard to treatment. And that's related when insurance plans are the same, that's related to the doctor who makes the assessment of what the treatment plan is.
Thank you so much. Great points. Anyone else want to add to that? Okay, I'm going to tug at your heartstrings just a little bit, and I want you to kind of think about what it was like May of 2020, and hearing George Floyd when he was murdered, and all the promises and things that we wanted to do differently once all that was to the forefront. So could you talk a little bit about what you hope to see a change in your particular environment and how that has been made, or what lacks thereof within your environment now? I know that's a tough one, but a lot of promises were made back then. And now that we're coming here 2 years later, do you see things that did happen, did shift, or things that we still need to really work on?
Are you talking about from a community perspective, from a healthcare
community and from your academic medical environment or your organizational environment?
Well, as you all know, that was just a really tough time to go through, and obviously brought out a lot of much needed conversation, both within the communities as well as within the academic institutions. I think that it allowed a lot of us to actually gain a voice where we didn't have one. But I often found that time to be particularly very overwhelming, because we went from never talking about it to talking about it of every second of every day, and everybody wanting to hear only your opinion. And once again, as being the few minority people on campus or in your communities, you often end up talking about it way too much. I think that one of the things that came about, at least the institution that I am in at Duke right now, is that the leadership did put a lot of money towards minority-based projects. We were given sort of a carte blanche to come up with things that would make things better for the institution, and they guaranteed that they would fund it for you. And so all you had to do was come up with the ideas and a project and a plan at Duke, and they would implement that plan to see if it would work and make things better. So I was very proud that at least on some aspects, Duke actually heard the community and listened and tried to find solutions. After a while, though, like everything else, it sort of peters out, right? You have this big old flutter of activity within months around something like that happening, and then you never hear about it again. And so I'm hopeful that with all of the initiatives that they were supposed to sponsor, that maybe we'll start to see some of that outcomes research in the near future, or, updates on plans that have actually happened. But right now, I think, we're still in the beginning of all of that.
Thank you so much for sharing. Anyone else?
A really tough question.
I, not to get off subject, but I'm just kind of thinking about what's coming to mind for me and what I'm feeling, right? And so that was a really difficult time. I think more so specifically for a lot of people of color, and then even more so for people of color who were in spaces of leadership, to have to, again, from my experience, sometimes have to compartmentalize my feelings, how I am carrying the weight of what I'm seeing daily while still trying to lead, was very difficult. And so that's what comes to mind for me. Not that I have a position on where we are today, but that was just on my heart to say that, and for people to understand that being, again, people of color, and then having these leadership positions and being exposed and still having to lead, leads to a lot of compartmentalizing and then having to deal with that at some point in some way or fashion. So, yeah.
Thank you so much for sharing. I know Carrie and I, we were actually at the university and worked together on a lot of things that we wanted to see happen within the next couple of years. So it's very tough. And I think that's something that we're continuing to work on. And I wanted to try to just get some perspectives from different people of some of the barriers and things they were able to accomplish. If some really did like a 180 and really was able to drive a different path, or do you still feel like you have a lot of work to do? And I'm sorry, Dr. Taylor, you were about to speak.
Well, I think we all have a lot of work to do. At Penn, within my department and within the medical center, I think we've made terrific strides. And I'm proud of what Penn has done. I'm proud of what our department has done. And it really runs the gamut. But here's my concern. My concern is the sustainability of these initiatives and programs that we've been able to institute. And how do we institutionalize them? How do we weave them into the fabric of Penn Medicine and the fabric of the Department of Dermatology, so that in 3 years or 5 years, institutional memory can be really short, that all of these disappear, right? So that's what I'm grappling with, and others are grappling with at my particular institution. It's not perfect what we've accomplished, but we've accomplished a lot. I'm worried about it disappearing.
Understandable, us too. Thank you so much for sharing. Anyone else have anything to add? So that brings us into the question about, we talked a little bit about some of the things that may have been implemented or started to be implemented 2 years ago and where you're kind of at. So can you specifically address some of those things that you've used within your organization to increase DEI? Maybe even your dermatology, ear, nose, and throat, students, have you seen some of the things that have been implemented and been successful, or some things that you feel like can be instituted throughout different institutions to also give them a leg up?
I can offer the student perspective.
Sure.
I definitely think there has been an increase in the amount of skin of color we see in our didactic lectures now. Of course, Dr. Taylor, you made a really good point about the sustainability of all this. And as I'm listening to you all speak, and as I listen to Dr. Allen speak as well, and a lot of other people on this call, I know that you all have already started a lot of this work when you were in medical school, or maybe even before then. And so I know that you've already started paving these paths. And I just fear that it takes such a long time that by time I'm practicing, as you said, the institutional amnesia is gonna kick in. And a lot of the work that we're doing right now isn't gonna be, we're gonna be reinventing the wheel again in the next couple of decades. So I just wanna make sure that stuff that we do right now is sustainable. And how do we do that? How can we do that as students? Because it's being done, but it needs to be done for forever.
I think I can add a little bit there. I mean, the fact that we're even coming together in a conference like this, where we've taken our Friday to talk about it and hear personal experiences, really means a lot to me. I have always just made myself fit in certain white institutions because I can, and that's just the way that I've dealt with things. But I do think there is a role for, I mean, clearly for inclusivity for all cultural backgrounds in educational settings. And I think this is one really great way of doing it. Having conferences like these, you know, it creates conversation, and it's more of a bandwagon type grassroots way of doing it, because you know, I will eventually be an attending, and I will eventually have other mentees of mine, and I'll pass that on to them. So I think that by doing this, we're reaching more and more people. There were 300 attendees this morning. I think that's amazing that people were here to learn about perspectives other than their own. And this is the way that we do it. And I do think that, yes, the institutional memory is short, like what Dr. Taylor was saying, but we are also here now, so we can continually move awareness in the right direction. And I think that once the awareness is at least in people's minds, it will shift slowly but surely in that direction.
Thank you so much. Dr. Bowers or Dr. Kanan?
From an institutional perspective, the first year that I came to Duke, they had an entire weekend dedicated to underrepresented minority students who are applying to any residency in the institution. So they bring them in house, provide for their food that weekend, and then they spend the entire weekend having people talk from dermatology, internal medicine, everybody giving their perspectives, and then also having people talk honestly about the wrongs that have happened over the years within the university and things that they are attempting to do to change that. I was very surprised. It was my first time ever witnessing something that degree and something on that magnitude being done across the campus to sort of capture and let people know that, one, we're trying, it's not perfect, but we'll get there. And so I think things like that can be impactful. Obviously, it's not the end of everything. And I think maybe if we kind of share from institution to institution things that work and things that other people are doing and we see that can make a difference. Because I think we're all just so siloed. I hear, what's happening at Penn, and oh, I know what's happening at Duke, and I may not know what's happening at another institution that helps. I can tell you that there are places where I know that students of color just feel protected. I just met two University of Kentucky, Louisville medical students at a American Head and Neck Society conference. They're applying to ENT. And they were just raving about their institution from a support standpoint. They basically said that if you're Black as a medical student, you need to come to the University of Louisville, Kentucky. And I would have never thought that in a million years. That's my own unconscious bias, right? I just assumed that that would be the last place. That would be one of the last places where you would feel comfortable. But apparently they talked about how protected they were across campus. One of them gave an example about how, typical scenario on the news, there was a Black guy in this black hoodie, or sorry, Louisville, Kentucky red hoodie that had committed a crime very near to campus, got away. And apparently the police came on campus and basically shook down any Black man in a red hoodie on that day. And apparently the institution literally took them down, basically said this will never happen again immediately. It was like an immediate, swift response that was done very well. And they were like, we are seen on this campus, and they feel very comfortable. And that's what we need. But again, how do we get to talk to this university to figure out what they're doing and what they're doing well, that students across campus are raving about what they do well, and make that something that can be a shared initiative that can be implemented at other institutions and be sustainable. And I don't know, because like I said, I came from a background of ENT where my chairman in residency made it his initiative to bring in people of color. And during the 7 years that I was there, we probably graduated the most minority residents there. He retired 4 years ago. There hasn't been a Black resident in the program since. Right? So it has to be intentional. It has to be done well. People have to feel included, but it takes that mentality and maybe the shared space where we can understand what people are doing well and implement that across all of the systems.
Yeah, thank you so much. I really like the transparency and talking about what's going to transpire and what the university is trying to do, because we know they're not perfect, but having that transparent conversation, I think, is important because people want to know the truth. Dr. Bowers, and then David, you can have the last word.
I just wanted to offer the, over the last couple of years, what's happened from the residency recruitment perspective, because as a program director, I felt, definitely, I have the privilege of this position of leadership, and definitely felt like, it's my responsibility, to help drive those changes that I know need to happen. And I'm so proud of my program because, we are in central Illinois, so it is, predominantly white area. And also, historically, our residents have been predominantly white. And, I knew that, part of, I think, what fuels me is knowing that staying continually positive, like, no matter what, you can always start somewhere, you can always do something. And to not get bogged down in feeling like, which I have to admit I did, because after summer of 2020, I felt, as someone who's not Black, I felt this and has had more privilege in my society. I mean, yes, I'm a person of color, but I'm not Black. And I felt this interesting space that I'm not often able to talk about being a person of color and experiencing bias and discrimination, but also not being Black, and kind of, wrestling with that. And, knowing how to use my privilege appropriately and to advocate for people who are more marginalized than myself, and feeling the sense of deep urgency. Like I have to do this, and I have to do this all now. And I have to tell you, was from a program director perspective, it was overwhelming, because I felt like I have to create curriculum for my residents. We have to change residency recruitment. We have so much work to do. And, I felt such a sense of urgency, and we know that change is slow, and also sustainable change, as Dr. Taylor pointed out, is really important. So, I think, there was things that I've changed over the years, but and sometimes it doesn't seem like change is happening, but then you look at some objective data and you see that change actually has happened. And, I just, for example, we interview 40 students every year, and this year, 19 out of our 40 were underrepresented in medicine. And that's higher than, what we've ever interviewed. And we've matched underrepresented medicine students 2 years in a row. And I mean, I know that doesn't seem like a lot for our program, but the delta is a big deal. And we've instituted curriculum and trying to really push and push and push. And again, it doesn't seem like things are changing, but all of a sudden you get conversation going, and then, your residents are advocating for things. And, it's really, I'm really proud. And that's coming from a space where I felt like, gosh, I'm not gonna be able to make change, and there's too much change to do. So I think it's just really important to recognize that, it takes time, and to Dr. Ananda's point, that it's so important to bring our mentees into this and our students into this, because this is where that legacy and that generational change comes in. Because mentoring our students who are empowered in these causes, they're bold, and they're going into this space in medicine, very different than some of us who've been here longer have been, and working on it together and breaking down those hierarchical relationships, using your experience as someone who's faculty and at leadership, but working more together is really, really powerful. And they bring ideas that I never would have thought of, and they're a whiz with skills that I am not. So, and then to Dr. Cannon's point that I really want to amplify, and then I'll shut up, I promise.
It's okay, you're fine.
Is learning from each other, because the other thing that I see that happens a lot is there's so much duplicity in our efforts. We're all trying to do things, and we've done holistic review at our program. We never did holistic, we kind of looked at people holistically, but we never really did formal holistic review. And we've come really a full 180, and that's awesome. But there's other programs around the country who are kind of wondering, how do you do a holistic review? But nobody really wants to share how they do it. And to me, I just think, why don't we share more? We don't have to work so hard, and it may not be the exact same formula, but we can share, and we can talk, and we can learn, and cross-disciplinary as well, because there's so much commonality in disciplines, like with ortho and ENT and derm and plastic surgery. So I guess I just want it from the faculty and program director perspective, so that out there that change can look like a lot of different ways. And I guess just to stay at it and really bring your mentees into the work.
Yes, thank you so much. That's called reverse mentoring, because I do mentoring here on campus, and it is really important that your mentees can teach you a lot that you don't think that they could do about technology and social media and things like that. So we're trying to implement some things like that here on our campus. So thank you for sharing. And David, and then Dr. Taylor, I don't know if you had another point as well. David, did you have a point that you wanted to make?
Yes, and I've been so encouraged by our medical students and residents here at OU Health. And Jamalje, I think it was one of your classmates, recently scheduled a meeting with senior leaders about how we could have sensitivity regarding our Afghan refugees that were coming into the state. And so then we started talking about continuity care for our Afghan refugee community. That led to a robust conversation on how there was other opportunities for us to advance equity throughout the system. And so, our students, our residents, you all really have been coming to the table with a new vision, and I'm so encouraged about this next generation of leaders that's stepping into healthcare. Also, as someone else mentioned, the process sometimes is a slow process, but just earlier this week, we were meeting about revised standards to reduce healthcare disparities from the Joint Commission. So soon the Joint Commission is now going to be mandatory, having us report on what we're doing to reduce health inequity within our communities. And they have a lot of data aligned with our social determinants of health. And so the more standards that we see coming into our healthcare systems is going to help us move forward together across the country in healthcare leaders. So I'm excited about the generation that is coming into healthcare now, and we're starting to see the standards change. So I'm very optimistic about the future of healthcare, but that doesn't negate that we have a lot of work to do, and we have to keep the conversation going, and we have to find ways to partner beyond our current roles, beyond our current institutions to move forward. And for me personally, I wouldn't be here at OU Health today if it wasn't for the May of 2020, because that's when the CEO made a commitment to hire a diversity officer and started a DEI council and move forward. And so sometimes there is not progress without protest. And so we're going to continue to have those protest moments that will help us move forward in this way of creating belonging for all.
Thank you so much. Anyone else have a comment before we move on to our question? Yes, Dr. Taylor.
I'd like to offer this to Dr. Cannon. In dermatology, our professional organization, the American Academy of Dermatology, created a symposium called Diversity Champions. And for 3 years, we have held this symposium and invited programs from across the country where we could share best practices around diversity, equity, and inclusion. And it's a wonderful, wonderful conference, very well attended. We teach other programs sort of best practices. You know, Dr. Bauer talked about holistic review. We talked about a holistic review, a whole host of things. And that way, that's where I met Dr. Allen for the first time, right? So people from programs all over the country were sharing what we've done. We get new ideas and different ideas. Like Dr. Cannon, you might not know, Duke Dermatology is the first program in the entire country that created a diversity and community engagement residency program with its own program spot, with its own ERAS number, with its own requirements. And we learned about that at Penn, and guess what? We have one now. And there's somebody I saw, one of our little blocks here, who's thinking about it for his program. So it's kind of the cross-pollination within our specialty. And I think it's something that your professional organization probably needs to head up. And I just want to send a shout out to you. You are fierce. Thank you for sharing your story, Dr. Cannon.
Thank you so much. I would absolutely love to hear more about that. I've actually just become our diversity leader of our program, and one of my close friends who is also a Black head and neck doctor became the diversity leader of the Cancer Center. And so we have to kind of put our heads together to think of ideas like this. And I would love to hear a lot more about that. Sounds phenomenal. Thank you.
Well, thank you all so much. I really appreciate it. And I know we went over our time a bit, so apologies for that, but I couldn't stop the conversation because it was so good. But I think we may have time or two. Dr. Allen, you can let me know for a question or some questions in the chat.
We are out of time.
Okay, that's okay.
But we can keep the chat going, and if those want to reply in there, that is fine. And if it's okay with our panelists, if you want to put in an email address or something, if those want to contact you individually, please feel free to do that. But we will go ahead and move on. I really appreciate this conversation. There is a person of, she's more of an author. Her name is Vera Monroe, and she basically said diversity is being invited to a party, but inclusion is being asked to dance. And so you know, it's not just only being in the room, but having that ability to be at the table, to have a voice, to be able to be at the table for decision making, and to make those positive changes that will bring about belonging and cultural awareness, and where DEI is interwoven within the fabric of our institution. And so I thank you all for your perspectives and responses today.